Hello, my name is Dr. Edelgard Wulfert. I am a clinical psychologist and I'm a professor of psychology at the State University of New York. I have worked in the field of addictive behaviors for over 20 years, and for probably 10 years I have worked in the area of gambling disorder, both from a clinical perspective and also research-wise. And I am here with my colleague James, who will now introduce himself.
Hello, my name is James Broussard. I have been in the field of addictions counseling for the past 10 years as a certified addictions counselor, first in the state of Louisiana and then moving to New York State. I have, for the past 6 years, worked primarily as a gambling counselor and also in the area of clinical research into gambling disorder, treatments, and different interventions. And what we'd like to introduce you to today is a new treatment which Dr. Wulfert and I have worked on and developed, which is Cognitive Motivational Behavior Therapy, which I'll allow Dr. Wulfert to tell you a little bit more about.
Okay. Cognitive Motivational Behavior Therapy, or CMBT as we have abbreviated it, is a treatment approach that combines two very well-known therapies. One is motivational interviewing, and the second one is cognitive behavior therapy, or CBT. And so we have combined these approaches for reasons that we will explain as we conduct our training.
And what we'd like to do is give you a general introduction to both of these approaches on their own, so that you can get a firm foundation before hopefully seeking out more specific and involved training in each of these approaches on their own or combined together in our approach.
So we will have one training tape that deals directly with CBT, cognitive behavior therapy, and we have a second training tape that then presents the basics of motivational interviewing, or MI. Now, I would like to emphasize something that is very important. These training tapes serve the purpose for you to learn the basic theoretical principles that are underlying these approaches, and for us to demonstrate to you how these approaches can be used for gambling disorder. The tapes are not intended to train you to a degree that you, after watching these tapes, will now be a competent therapist who will apply either CBT or MI. So that's not the intention of these tapes. The intention is for you to receive an introduction, because on the assumption that you are not really very well versed or very familiar with either CBT or MI. Hello again, this is Dr. Edelgard Wulfert. In this webinar I will present to you a primer of cognitive behavior therapy and its application to gambling disorder. The purpose of this presentation is to give you an overview of CBT. It is not intended to train you as a CBT therapist. What are we going to cover in this webinar? I will provide a general overview of CBT, the context in which it was developed, and its role in contemporary psychotherapy. And to accomplish that, we will review the principles of CBT, including its central assumption, which is that dysfunctional cognitions, such as unrealistic or false beliefs and expectations, generate negative emotions and lead to dysfunctional behavior. CBT emphasizes the importance of cognitive interventions, but the therapist also uses behavioral interventions such as skills training, problem solving, and relaxation training. The basic assumption is that there is a reciprocal relationship between thinking, feeling, and doing. and so intervening on one level will change all the others. We will also address the therapy process in CBT. Of particular importance is the role of the therapist and the client. They both play active roles and develop a collaborative relationship. And we will discuss the importance of a thorough assessment of a client's problem via functional analysis of behavior. We also call that the ABC model: antecedents, behavior, and consequences, and how a functional analysis leads to a good case conceptualization. And lastly, I will talk about how to implement CBT for problem gamblers and how to use it for relapse prevention. So this was a brief overview, and now let's get started. Let's begin with a general overview of CBT. What is CBT? CBT combines cognitive and behavioral therapies. It grew out of behavior therapy but places greater emphasis on the cognitive element. Specifically, it raises clients' awareness of the interplay of 6 elements: the situation, cognition, emotion, physiology, behavior, and consequences. Let me give you an example. Imagine that a boss calls his secretary to order because she has repeatedly forgotten to remind him of important appointments. The secretary thinks, "I have so much work, this is really unfair." She now feels upset and she gets angry. Her heart rate increases, and since she's upset, she begins to talk to co-workers and she complains about her boss. The consequence is that someone takes it back to the boss, and now the boss doesn't trust her anymore. So you see, this was a chain that showed you how a particular situation leads to thought processes, emotions, and physiological reactions, and behavior, and finally the consequence of behavior. CBT has a very long history. It is about 60 years old. Its early proponents were Albert Ellis and Aaron Beck. Albert Ellis developed rational emotive behavior therapy, later only called rational emotive therapy, about in 1955. And he was one of the originators of the cognitive paradigm shift. He was a very charismatic person, a professor at Columbia University, and he was famous for his Friday night workshops in New York City. In these workshops, he entertained an audience and always got volunteers from the audience to come with him on stage, and he demonstrated his approach of challenging irrational cognitions and having the person adopt rational thinking. In a survey in 1982, Albert Ellis was considered to be among the 3 most influential psychologists, together with Carl Rogers and Sigmund Freud. Now, another very important proponent of CBT is Aaron Beck. He is a psychiatrist, originally at Penn State. Later he formed his own institute. Aaron Beck is about 94 years old, and he developed his approach in the early 1960s, and he was particularly well known for his cognitive behavior therapy for depression. He's the person who coined the term automatic thoughts and argued that depression results from distorted thoughts or distorted views of the self, the world, and the future. Now, CBT is, next to behavior therapy, the most widely researched psychotherapeutic approach. It enjoys a very strong empirical support and has been very successfully applied for depression, anxiety disorders, addiction, and personality disorders. Indeed, CBT is the dominant approach not only in the United States but also abroad. And now let's look more closely at the principles of CBT. The central tenet of CBT is that there is a reciprocal relationship between thoughts, feelings and behavior. If thoughts are dysfunctional, then the person will have negative feelings and engage in maladaptive behaviors. False beliefs and maladaptive behavior in turn will lead to adverse consequences, and they can be immediate as well as delayed. And so eventually this entire cycle creates problems and a lot of unhappiness for the person. Let me give you an example from our own clients. We have run for a number of years a federally funded research project here in Albany, New York, with the Center for Problem Gambling, where we have seen a significant number of gamblers over the past 5-6 years. So we had a woman who at some point played scratch-off tickets, and she won a significant amount of money. And this happened to her just before school started, and it was the first time, as she said, in her lifetime that she was really able to buy all the school supplies for her children and to buy them some clothes, and so she was incredibly happy. Now, this set the stage for her to gradually develop a gambling problem, because she now had that belief that if she was lucky, buying some scratch-off tickets might resolve all her financial problems, and she might be able to repeat this issue. And so she began to buy scratch-off tickets with money that she really could not afford to lose. And so particularly always before school started, she spent a tremendous amount of money, and the problem became more and more severe until she finally ended treatment. And so you can see how a particular belief, and that is that it's possible to win money and to resolve problems that she had with getting the money together for her children when school started, that she could resolve these problems by buying scratch-off tickets. And just because it had happened once, of course she hoped that it would happen again, that she would have a significant win, and that would resolve her problems. And of course she did not repeat the win, and so she got further and further into a deep hole, and this is what got her into treatment. Now let's talk about the principles of CBT and the graphic display here on your monitor that shows the reciprocal interactions between cognition, emotion and behavior. See that each element influences the other two. Thus, changing one element will likely have an influence on the other two. And so now let's look at the role of cognition in CBT. Your thoughts and interpretations of a situation generate emotional reactions and often also physiological sensations that affect your behavior. And many of these thoughts are automatic in a sense that they are semi-conscious and not deliberately evaluated. Now the emotional and physiological reactions in turn will affect what you do and what you think. Again, there's a reciprocal interaction. And similarly, what you do in a given situation will affect how you feel and think. Let me give you a practical example. Assume you work in an agency and a promotional opportunity arises. You apply, and after a couple of weeks you learn that one of your colleagues got promoted. So now here are 3 possible scenarios how you might deal with this knowledge. One scenario would be that you think, I'm really better qualified than John. This was unfair. So what happens? You will feel upset, angry, possibly even jealous of John. And since you feel upset and jealous, you may become uncooperative and you let things slide. Now let's look at a second possibility. Again, same scenario, but this time you say to yourself, My boss thinks I'm not qualified. I will never get promoted here. If you think this way, you will probably feel deflated and down. You ruminate and your work will begin to suffer. And here's a third possibility. You might think, John has more experience, but with time I will acquire more experience as well, and then I will be up for a promotion. If you think this way, then you will feel okay about yourself and possibly even happy for John. And most likely you will work harder to get ready for the next promotional opportunity. So these examples show that the way you interpret a situation or an event will influence how you feel and behave. And so this is at the core of cognitive behavior therapy. A CBT therapist helps clients assess whether their perceptions are correct or whether there are possible errors in thinking that could lead to a reassessment of the situation and a different course of action. So in essence then, helping clients to challenge their beliefs and changing the way they misperceive or misinterpret events will change the way they feel and the way they behave. Now, similarly, if we help clients stop their habitual reactions in a situation and behave differently, this will change the way they think and feel. So, how do we accomplish this? In CBT, we have a term for that, and we say the therapist uses a collaborative empiricist approach. That means that both the CBT therapist and the client work together to examine the evidence that supports or does not support the client's belief, so that the client can recognize possible cognitive distortions. Now note, this is different from telling a client they are wrong. So if you just tell a client, well, the way you think about the situation is incorrect, this may elicit defensiveness. So to avoid defensiveness, the therapist uses Socratic questioning and invites the client to generate evidence for and against their beliefs by asking questions such as, how could we find out whether this is true? What evidence do you have that this thought is true? And what evidence do you have that the thought may not be true? And what is the worst thing that could happen if the thought were true? So the purpose is for clients to recognize possible false beliefs and to normalize their experience, or to realize that even if their thoughts are true, it would not be the end of the world. Now let's look at the therapy process in CBT. All therapies, be that CBT or IPT or behavior therapy, all therapies contain so-called specific factors. They are considered essential for clients to get better. These are factors that are derived from the theory underlying a particular therapeutic approach, and they express themselves in techniques such as cognitive restructuring in CBT or achieving insight in traditional therapies. But since therapy is a human relationship, there are also so-called non-specific factors. They are common to most therapies, and one such factor is the therapeutic relationship, also called the therapeutic alliance. Here are some important therapist characteristics that make for a very positive therapeutic alliance. A therapist who is warm and shows empathy. That is a therapist who validates the client's experience. A therapist who is authentic, who is honest, not hypocritical, and who shows congruence between verbal and non-verbal behavior. A therapist who shows a regard for the client, that means who respects the client. And a therapist who is non-judgmental and also respects the client's autonomy. So these are characteristics that are important in the therapeutic relationship. In CBT, the therapeutic alliance is very important because the relationship between the therapist and the client is collaborative. It's teamwork, basically. And so this requires trust and positive regard on both sides. So now let's look at the therapist role. In CBT, the therapist is very active and directive. The therapist has the role of a coach, you might say, or a counselor. Okay. Active means that the therapist encourages a give and take in the session. The therapist is not simply reflecting what the client says, which would be a hallmark for client-centered therapy. The therapist actively directs the session towards specific goals. But that is very different from a therapist to be bossy or telling the client what to do. It means that the CBT therapist, through well-formulated questions and dialogue, guides the client in the desired direction. Let me give you an example. A therapist might say, "It sounds like when you started gambling, there were many positives, but over time the financial consequences and the costs to your marriage have increased. How would your life be different if you decided to stop gambling?" The client might say something like, "Well, I'd have more money and my wife wouldn't be so upset with me." And so the therapist might reply, "So would this be an acceptable goal for us to work on, helping you stop gambling?" So you see, this is quite different from saying your gambling has caused you financial and marital problems, and so if you want to solve them, you need to stop. See, the last one would be directive but almost confrontative, whereas the former was also active and directive but in a very subtle way, so that basically the client can accept the goal much more easily and does not feel that the therapist is kind of mandating certain behaviors. Now, in CBT, the client also assumes an active role. The client is an equally active participant in treatment, and that requires that the client bring a certain motivation to treatment, and the client must assume responsibility for learning new self-control skills. The client must also be willing to complete assignments between sessions and to practice and implement new skills. So this is the essence of a strong working relationship in CBT. You have an active therapist and an actively involved client. Another important aspect of CBT is that it is problem-focused. The goals of CBT are treating a problem behavior such as gambling and changing it so that it is no longer a problem. So, for example, achieving abstinence or at least decreasing gambling to a non-harmful level. So, symptom relief and changing problem behaviors is an essential goal in therapy. And this goal in therapy is set collaboratively and achieved collaboratively. Now, CBT stands in contrast with traditional insight-oriented therapies in that the emphasis is not on insight in the traditional sense, but on behavior change. But behavior change sometimes comes about through increased self-awareness. The CBT therapist helps the client become aware of automatic thoughts, beliefs, expectancies, and core beliefs and their relationship to the client's behavior. So in that sense, undoubtedly, increased insight and awareness are obtained. Let me add a word about so-called comorbid problems. People with very severe comorbid problems, such as serious substance abuse problems or a psychotic disorder, And also people in an acute crisis may need to be referred until the immediate problem or the crisis is resolved before you can begin a problem-focused treatment for gambling disorder. We have found it almost impossible to treat someone for a gambling disorder if the person at the same time has a significant substance abuse problem. We either have treated such individuals concurrently with someone who has treated the substance abuse problem and we have focused on gambling, or we have asked the client to first get the substance abuse problem under control, and then we have ended the client in treatment for the gambling problem. Another important part of CBT is that it is a structured approach. It is not simply having continuous meetings with a therapist where the client recounts the events of the past week. Rather, CBT is focused and problem-oriented, and the sessions have specific goals. So, for example, when you work with gamblers, you help the client understand the CBT model, identify high-risk situations, automatic thoughts and cognitions and errors, and you help the clients challenge these errors and adopt a more realistic perspective. So clients are active participants and they are willing to practice what they learn via homework assignments. CBT is also skill-based. The therapy is geared toward increasing clients' awareness of distorted beliefs and helping them acquire a new skill to achieve and maintain abstinence, or at least significantly reduce their gambling. This is done through cognitive restructuring of false beliefs and also through problem solving and coping skills training. So, in other words, we are employing a variety of cognitive and behavioral interventions to assist the client in solving his or her problem. So now let's talk about how we understand what drives and maintains a client's problem. The basis for a good understanding of the client's problems is the functional analysis. It is based on the assumption that behavior is shaped by antecedents and consequences. Antecedents, or we sometimes also call them activating events, occur before the behavior. They are typically complex. They may be consisting of external events, we call them triggers, or high-risk situations that make it more likely that the problem behavior will occur. And there are also internal events. They are often semi-conscious automatic thoughts and beliefs, expectancies, perceptions. There are also feelings and physiological reactions. So this entire group of internal and external events is what we call antecedents. After the antecedents comes the behavior in reaction to the antecedents, and the behavior is associated with consequences. These consequences can be internal, emotional, for example, and external. They are often social consequences to what we do. The consequences can be positive or negative, and they can be immediate or delayed. Let me give you an example. Think that somebody in the morning is driving to work and they are in the habit of stopping at a convenience store such as Stewart's to get some coffee. So the external antecedent is going to work and stopping at a convenience store. Now at this convenience store they also have scratch-offs, and so the person perceives that one roll of their favorite scratch-offs has almost all sold and no significant win has been announced. And so now here comes an internal antecedent. The person now thinks, the roll is almost empty and there hasn't been any win. And so now that creates a feeling of excitement and anticipation and possibly even a certain physiological arousal with increased heart rate. So these combinations of external and internal events lead to behavior. And what is the behavior? Aside from coffee, the person now also decides to purchase 15 scratch-off tickets and spend $75. Okay? And the behavior now leads to consequences. And that is, after scratching off the 15 tickets, the person has one winning ticket with $5. So he has lost $70. Now the immediate consequences are disappointment and a sinking feeling, and the delayed consequences are that he now doesn't have enough money because he has lost money that he couldn't afford to lose. There's an argument with the spouse because a bill didn't get paid, and the person now experiences low self-worth. So you see how antecedents, behavior, and consequences are interrelated. Now, a good functional analysis is the basis for good case conceptualization. The case conceptualization serves to gather information and to establish rapport with the client. And it provides a framework to understand the client's concerns and current functioning. A case conceptualization quite often is not done within one session, but by the end of the second session you should indeed be able to have at least a preliminary case conversation. To facilitate the process, we recommend that you start with a problem list. A problem list helps you understand the client's psychological, social, occupational, and financial difficulties. And then you can use the ABC model to assess triggers. Think of external and internal antecedents, thoughts and feelings. The behavior. If you're dealing with a gambler, you would want to know the frequency of gambling and the severity of the gambling. And consequences. What are the immediate and the delayed, positive and negative consequences of the behavior? Now, a good case conceptualization helps you create a treatment plan and set preliminary treatment goals. Note, it's important to reassess periodically whether the treatment plan functions as anticipated, and if not, you need to change the treatment plan. The important thing is that you should always share your treatment plan and your case conceptualization with the client and ask for feedback, because you want to make it a collaborative enterprise. Let me give you an example. You might say to the client something like that. So, well, in this initial conversation we have identified some situations and also some thoughts and feelings that seem to contribute to your gambling difficulties. You have often had urges to gamble after an argument with your wife, and you have also had urges when you are bored and when you have nothing to do. And finally, you have reported urges when you have money problems. So it seems that these are the situations in which you tend to go to the casino, either to forget it all, or just to feel alive and excited, or to win some money because you think that will solve your problems. Now, over time, you have accumulated quite a bit of debt from your gambling, and that concerns you. You have also stopped doing things that you used to enjoy at some time, such as going to the movies with your wife, or taking your children bowling, or even going fishing with a friend. So now, I would like to recommend that we further explore your thoughts about the role of gambling in your life. And I would also like to talk with you about ways in which you could resume some of the activities that you used to enjoy before you got more involved in gambling. So what do you think if we made these targets for treatment? So you see, you are involving the client actively by explaining how you see the problem and what you envision could be some preliminary goals for treatment. And so if the client agrees, then you will set these goals, and you will periodically assess whether the goals are being achieved, And if not, then you need to identify obstacles and reformulate the goal. And this is always done collaboratively with the client. So before we now turn to the application of the CBT model to gambling, let's quickly assess what you have learned so far.
Let us review. Please pause the video and take the next minute or so to answer the following questions. When you are done, hit play and you will be provided with the answers. If your answers are incorrect, please refer back to the relevant sections of the presentation or your handout for further review. Let us begin.
Now let's apply the CBT model to individuals who present with a gambling disorder. When is CBT suitable? Clients who benefit most from CBT have a strong motivation to change. These are clients who come voluntarily into treatment. They have positive expectations for treatment, and they also have a clear treatment goal. Sometimes we have clients who are referred either by a probation officer, or sometimes clients have been threatened by their spouses with divorce if they do not get treatment, or we have had clients who have lost their jobs or who have embezzled money and feel under a lot of pressure. We have been able to help some of these clients, but when the motivation is not internal but comes from a strong external motivation, you need to work very hard to increase the internal motivation, because if the motivation is exclusively from the outside, the client will leave treatment as soon as the external pressure has been taken away. So a client will benefit from CBT if the client is willing to make a commitment to therapy. And that means the client is willing to devote sufficient time and effort to treatment, and will attend weekly sessions, and will also be willing to do homework assignments, which is a significant part of CBT. The client who benefits is also an individual who has sufficient education and cognitive functioning. A client probably should have at a minimum a 9th grade education, because you often assign reading materials, and the client has to have the capacity to understand the CBT model and can handle independent readings and also carry out in between session homework assignments. Another issue is life stress. Clients who have very high levels of stress tend to have multiple crises, and then that leads to unfocused crisis management rather than a productive work session. Such individuals may do better with crisis intervention and supportive therapy until the situation has stabilized, and then of course you would switch to CBT. Also, clients who have social support in terms of family or friends often benefit more from treatment. Indeed, we tend to include supportive family in some aspects of treatment because we have found that this leads to better outcomes. However, of course, we also have clients without social support, and we have found that they may benefit from a referral to a group such as GA Gamblers Anonymous, in addition to receiving individual treatment. I'd like to say one word about severe comorbid psychopathology. Clients with very serious comorbid disorders, substance abuse, a serious mental illness, access to diagnosis, tend not to benefit from brief or problem-focused CBT. They require more intensive and longer-term intervention. CBT is a treatment approach that is very useful for these types of interventions. I'm raising this issue only because in such cases you may not be able to focus on the gambling problem right away, but rather you need more time and you may need to focus on some comorbid pathology that might be more important to address before you can even begin to address the gambling problem. Okay? If you work for an agency where you are not allowed to do long-term therapy, but rather where your interventions are time limited, let's say 6, 7, 8 sessions, something like that, okay, then you should refer individuals who have a very serious comorbid psychopathology, because you will not be able to help such individuals in such a short period of time. Now, when you take on a gambling client, it's very important to provide a rationale for the treatment and to talk to the client about CBT. So first, you might want to give an overview of the cognitive model to the client. Here, you see it again on the right side of your screen. Explain to the client how thoughts and feelings and behavior are associated. Most clients believe that feelings are caused by particular events or situations. So, for example, when a wife argues with her husband over finances, he may get very angry, and then he may say, I need to relax, and he goes gambling. Okay? So now, if you ask him, he will tell you that what caused the problem, or what caused him to go gambling, is the fact that he had an argument with his wife and that he felt very upset. However, you need to explain to the client that there's something else that happened between the argument and feeling upset. And so you help the client dig out the thoughts that intervened here. And so what were these thoughts? These probably were thoughts such as, my wife doesn't respect me. She thinks I'm a bad provider because we don't have enough money to pay our bills. Now, it is these thoughts that generate the emotions. The person feels upset, angry, but also hurt. And it is these feelings then that in turn create the motivation for the behavior. So, as you can see, it's not the external situation that leads directly to the feeling, but rather it is the interpretation of the external situation, of the argument with one's spouse, that now leads to particular feelings and in turn to the act of gambling. The cognitive model suggests that it is largely what we think, believe and expect in a given situation that generates how we feel and what we do. And so you can explain to the client that you will help the client develop more adaptive habits by helping them, A, to view the situation from different perspectives, and B, to develop constructive alternative behaviors. Then please also emphasize the treatment process. Find out what a client knows about therapy. Maybe the client has been in therapy before and has certain expectations. Or maybe the client thinks therapy is a place to vent one's problems. Or some clients may have the expectation that it's the therapist's role to tell the client what to do. Explain that in CBT, the therapy is a partnership. The therapist and the client work together so that the client can better understand their emotions and can learn to solve their problems. And finally, it's very important in the first session to instill hope. Clients who have positive expectancies about treatment typically do better. This is a research finding that has been replicated many, many times. Please emphasize that CBT is an effective treatment. It has a strong foundation in research and has helped people with many different problems, including gambling problems. Also emphasize that you as therapists are committed to help the client learn better coping and problem-solving skills. And if the client is committed and is an active participant, then treatment will be successful. So it is important, especially in the first session, to instill hope in the client so that the client really develops the expectation that this approach will be useful. I would want to also raise one other caveat. You may be aware that gambling clients are significantly more suicidal than the population in general. So it is always important to assess suicidality right in the first session. Then you will do a functional analysis of the client's problem behavior, because the functional analysis is the cornerstone of CBT. It might be best to ask the client about a recent gambling episode and to use it to explain the ABC model to the client. So when the client explains what happened as he or she went gambling the last time, so ask about the antecedents, anything that came before the decision to gamble. So what was the high risk situation? What event happened? What were the client's thoughts and beliefs in that situation? What did he or she expect? And what feelings did and what emotions were caused by some of these expectations? What other sensations did the client experience? Were there any cravings or urges, and so on and so forth? Then assess the behaviors that occurred, not just the gambling behavior, but also associated behaviors, such as where did the client get the money from? Did he go to the ATM and get money? Did he borrow money, or things of that kind? So these are all the behaviors that surround gambling. And finally, the consequences. So find out what happened after the gambling episode had come to an end. Were there positive consequences, such as excitement? Did the client win? Were there negative consequences, such as guilt or anger, disappointment because the client lost money? And then also find out if there were immediate versus delayed outcomes. Delayed outcomes are often disastrous finances or significant problems with a spouse, threats of separation or divorce, and things of that kind. In the next slide, let me show you an example of a functional analysis. So here is an example of a form that you might want to use to teach a client in session the concept of a functional analysis. So you start with a recent gambling episode and fill out the form together with the client. And as you see, let's look at here column 1, 2, 3, 4, and 5. And let's start out with what led to the decision to gamble. So what was the high risk situation or trigger? As you see here in this example, so there was an argument with the spouse over money, and of course the argument was because there wasn't enough money to pay the bills. So based on this argument and on the fact that money was lacking to pay the bills, the individual now had all kinds of thoughts, and they are in the second column. So one of these thoughts is, we are broke. And then another thought was, well, I could win some money. I'm feeling lucky, and if I just keep my cool, I may be able to win some money. These thoughts in turn were associated with emotions in column 3. Okay, through the argument with the wife, the client was angry and frustrated, but then the thought that he might be lucky and might win some money also instilled a feeling of hopefulness, and he was excited at the thought of winning money and solving the problem. And so then this led to the following behaviors. The client went to the ATM and took $300 out, because of course this was the investment that he thought now to increase. And so he drove to the casino, he gambled, and what happened was he lost the $300, and so he went back to the ATM and took out an additional $200. And now what were the outcomes or the consequences? Well, there were initial consequences. He first felt excited when he won some, but then of course the excitement vanished very quickly because he began to lose and he felt guilty. And then later on he also there were delayed consequences because he now had a fight with his spouse because he had wasted more money that they did not have to waste, and he now also felt shame and guilt and despair. So this is an example that you can do in a therapy session in order to teach the client how to do a functional analysis. And I would recommend that you continue with other examples in session. And then you give the client a homework assignment to do a functional analysis for any gambling episodes that might occur between sessions. And if the client did not gamble, then the client could also use exactly the same approach just for urges to gamble, even if the gambling did not occur. So what was the high-risk situation that instilled the urge? What thoughts were associated with the urge? Aside from the urge, were there other emotions? What behaviors did the client engage in to deal with urges? And what was the final outcome that followed these behaviors? Here is what a completed homework assignment should look like. So you see the client here had 3 episodes. As you see, there were 3 different situations: an argument with the wife, home alone on a Sunday and nothing to do, and then the wife's birthday upcoming and not having enough money to buy a gift. And you see each one of these situations instills particular thoughts and also feelings, and each of them lead to gambling behavior, and there are specific outcomes that are positive and there are negative outcomes, okay? And so it should be possible for the client to complete such a homework assignment, and if the client does not complete the assignment, then I recommend that you complete it in session and try to find out why the client did not complete the assignment. You need to pay attention. It is possible sometimes clients have a writing problem and so they feel embarrassed, and you can tell them that they don't have to write anything lengthy, but rather just keywords would be fine, and explain to the client that research really has shown that clients have better outcomes if they actually practice what they learn in session, and that means that homework is important. And if nothing seems to work, then I recommend that you do a functional analysis in session about not doing homework. So in other words, what are the antecedents, the thoughts associated with not doing homework or with having to do homework, and the feelings, okay, and what is the behavior and the consequences. So you see, this is a very flexible method, and you can also use it in order to get through some barriers, and maybe that will motivate the client then to conduct to do the homework. Now let's look at a case conceptualization. You can use the ABC analysis to develop a case formulation, because the ABC method allows you to understand the client's problem, behavior in context, and you can develop a treatment plan and set treatment goals. So you might want to share your formulation with the client and educate the client about the problem. So this is quite similar to what I had mentioned before. So you might want to tell the client that you have identified certain situations, thoughts and feelings that are contributing to his difficulties. You can talk about the history, and you can say you have begun to gamble about 5 years ago, and it was at first fun, but over time you have incurred more and more losses, and your gambling has increased, and that has led to difficulties in your life. And so you have spent more and more time gambling, and you currently have about $12,000 in credit card debt. Now, the financial situation, the time that you spent away from home have caused increasing problems with your wife. And so now when arguments ensue at home, or when the money pressures increase, you seek relief by going to the casino and get away from it all. And you believe that if you just play carefully enough, and if you keep your emotions under control in blackjack, then you can win back the $12,000. So in the next session, I would like us to look a little bit more closely at the beliefs about the odds of winning in casino games such as slots or blackjack. And I think we might also explore alternatives to the way that you have been trying to deal with negative emotions resulting from your marital difficulties and from your financial problems. And then maybe we could also talk about alternatives, things that you used to enjoy before you became more and more involved with gambling. So what do you think about these goals for treatment? So you see, again, this is a case formulation that you can share with the client, and you ask for feedback. It's very important to understand whether the client really agrees with the way you see the problem. And again, you use this time to instill hope, because you convey to the client that there is a solution to the problem. Then another important part of therapy is goal setting. Discuss with the client what goals he or she would like to attain in treatment. Does the client want to stop gambling altogether, or simply reduce gambling? If clients want to only reduce gambling, I would discuss the pros and cons of such an approach. I would not deny the client the right to set his or her own goals. I would just use, based on my experience, some caveats. But I believe the client has a right to set treatment goals. A treatment goal could also be to improve the relationship with the spouse. So the important thing is that you formulate the treatment goal in behavioral terms, and that you specify steps in which each of these goals could be achieved. Now, once the goals are set, it's also important to identify potential barriers. What may be getting in the way to achieve the goals? So, for example, are there high-risk situations that may sidetrack the client and may get in the way of the goal? Or is the client bored? Does the client not have hobbies or any other interests? And might that be getting in the way? And now, so how can the client remove some of these barriers? I think here it would be important to use maybe a problem-solving approach, particularly for clients who cannot come up with particular ways in which they might actually deal with potential barriers. Problem solving, you can use a so-called solved approach. This is an acronym that stands S for select a problem, O, have an open mind to all solutions, in other words, to brainstorming, L, list the pros and cons of each problem. V, verify the best solution. Rank order the individual solutions and then select the one that you believe is best. E, enact a plan, including the steps and the time frame by when the solutions should be in place. And D, decide if the plan worked. So this problem-solving approach, if you are not very familiar with problem-solving, you can find significant information on the internet, and there are also manuals for problem-solving therapy. Another way to remove barriers would be to change certain habits that lead to the high-risk situation. For example, if a high-risk situation is to have a paycheck in one's pocket, well then maybe for at least for a particular time, the spouse could take on the finances. A person who buys scratch-off tickets compulsively might go a different way to work and might buy coffee at Dunkin' Donuts rather than at Stewart's, because Dunkin' Donuts doesn't sell scratch-off tickets. So changing habits that makes it less likely that gambling occur is also a very good way of dealing with the problem. And finally, try and find someone who can help. If the gambler has a spouse who is supportive or a friend, let's enlist the spouse or the friend. Another way is to join GA and to get a sponsor. That can also be a very, very useful intervention. Or finally, rely on the therapist and later on an aftercare group. But these are the steps in terms of goal setting, barriers, how to deal with barriers, and where to get help. An extremely important approach in cognitive therapy is cognitive restructuring. As we had said before, the central assumption of CBT is that dysfunctional behavior comes from exaggerated or irrational thought patterns, so-called cognitive distortion. And so the essence of CBT is to develop accurate perceptions that will lead to more adaptive feelings and behaviors. So how do we challenge maladaptive thoughts and incorrect beliefs? Well, we teach the client to start from the assumption that a given belief may be incorrect. And then we work with the client and help them examine the evidence for and against a given belief by using the Socratic method. This means we ask brief, open-ended questions in a non-judgmental way. This is especially important for gamblers because gamblers have a lot of superstitious beliefs, and if you just simply tackle them head-on, they may simply become entrenched and not be willing to let go of their beliefs. So, for example, a gambler might have the belief, today is my lucky day. I just simply can feel it. And so if I go to the casino today and play the slot machines, I can feel it, I'm going to be lucky. And so a Socratic approach to this belief might be, so let me see if I understand this correctly. So you sometimes can feel that you're going to win. Correct? Could you give me an example when this happened? Okay. Now, has it happened to you that you felt you were going to win, but then you didn't? Okay. So how could we find out whether your feelings really are accurate predictors? So you see, this is just one small example in which you could, with your questioning, begin to cast a certain doubt on the veracity of the client's belief. The client may indeed believe that feelings can predict the outcome, but of course they cannot. However, just telling the client that feelings cannot predict what will happen is probably not going to help. However, if you begin to question the client and the client sees that, well, actually, yes, I have had feelings to win and then I ended up losing, and so from that perspective, it is much easier and much more powerful to help a client change certain behaviors. Gamblers believe that they can influence games of chance, such as slots or blackjack, roulette, and to use strategies to beat the house. But in all games of chance, the house always has an advantage. So in the short run, it's of course possible that one can win some games, but in the long run, the house always wins. And since the house has the advantage, the longer a gambler plays, the higher the losses he or she will incur. And that's exactly when you have a gambler come into treatment, that is this person's experience. They started gambling at some time, and then they became obsessed with gambling, and they went more and more often and for longer and longer times. And now you see the effects of the house advantage. This is why the gambler then has lost more and more and more money. This is the inevitable outcome of games of chance. They are set up in such a way that the house has an advantage, and so the longer you play, the more you're going to win. So, by definition, the outcome of games of chance can neither be predicted nor controlled. By that I mean influence. And yet, gamblers quite often have an idea that somehow they can change their luck and they can influence games of chance, be that slot machines or roulette or craps or blackjack. And yet these are all games of chance, and nothing that the gambler does can influence the final outcome. There is no strategy that will in the end beat the house advantage. We have in our research lab a computer program called the simulator. It was actually my colleague James Broussard who developed that, and we have it at this point to mimic a slot machine and also to mimic scratch-off tickets. And so what we have allowed gamblers to do is they can within a short period of time play thousands of trials. We have a feature in the simulator that allows us to play to see the outcomes of 50 trials all at once. And so with that we can play thousands and thousands of trials, and we can demonstrate to the gambler that the rate of return in a game of chance is always negative. So yes, there are wins and losses, wins and losses, wins and losses, but the trend line is negative. So in other words, this is a very compelling demonstration that it really is impossible in the long term to win at a game of chance. And so we use that in some cases also for treatment, and of course we have used this for research, and we have shown that individuals who have used the simulator indeed are subsequently less likely to gamble, because they really have now experienced that their beliefs were false. Another method is a thought record. We have found it very useful to employ a thought record. In such a record, the client identifies situations and beliefs and feelings, and then finds evidence for and against the beliefs and develops accurate alternative thoughts. On the next slide, I will show you an example of such a thought record. So here, this is a form that you could give the client, okay, where it specifies the situation, thoughts, feelings, the believability of thought, evidence to support the thought, and evidence against the thought, an alternative response, and the believability of the response. So here is a record from a gambler who has been in treatment with us and who had still automatic thoughts, but we have given this individual a lot of information about how slot machines work, and so the person has learned something about slot machines. So if you quickly read the situation, or the event is that he finds himself at a casino and he plays a $5 slot machine, and he believes now that this machine hasn't paid off in all afternoon, and so it's bound to pay off now anytime. And the feelings are, of course, excitement and hopeful, and the believability of the thought is scored a 95 on a scale from 1 to 100. Now, we asked the person to generate evidence for the thought, and what he told us was there was an event where a cocktail waitress at a casino pointed to a particular slot machine and said that this machine hadn't paid off all afternoon. And so he sat down, and after only 10 minutes, he won $500. Okay. Now, we also asked to generate evidence against that thought. And what he said is he has also played other slot machines that hadn't paid off in hours, but a big win never came. And so finally, the alternative response was that he had read about slot machines. This was the readings that we had given him. And he knows that these are now computer-controlled machines, and they're not pre-programmed to pay out a certain number or a certain amount of times, okay? But rather they have a random number generator inside, and it is completely unpredictable. They could have losses in the long run, and there's no schedule by which one could predict whether one would win or not. And so the believability of this response was 80. This person subsequently was really able, based on what he had learned about the functioning of slot machines and about the negative rate of return, to eventually let go and to understand that slot machine play is a losing game. You cannot, you are bound to lose money on a slot machine. And even if you won $500, this is a rare win on a slot machine. Even if you win $500, if you continue playing, you will put much more in than the $500 that you have won, and you will lose more money. Let me show you here another thought record that is also useful to examine events other than direct gambling, but events that are often precursors to gambling. Again, this is a client whom we have seen, and this person came to a session, and he was very upset because his wife, he had a big fight with his wife, and his wife told him that she wanted a separation. And so we worked with such a thought record because, the question is, what does it mean to him that his wife wants a separation? And of course, the automatic thought was, she doesn't love me anymore because I don't make enough money and I cannot give her the lifestyle she wants. And that created, of course, very negative feelings, anxiety, hopelessness, and so on and so forth, and a very strong believability of these thoughts. And now we asked, well, what is the evidence for your thought? And he said, we have had a number of fights about money, and she has complained about us not having a nice vacation, having had a nice vacation in years, and we haven't even been able to go to Disneyland on a vacation, even though this is something that you had promised for the children. And now we asked, what is the evidence against the idea that his wife does not love him anymore. And so he said, well, my wife is probably angry and also sad, and so if I promised to stop gambling and she saw that I was really committed to changing and paying more attention to her and the kids, I don't think she would want to break up our family. And then he scored that with a 70. Okay, so you see how you can use a thought record as a means to identify beliefs that may or may not be correct, and you have the client generate evidence for and against the belief, and then this is a very useful intervention in which you can do cognitive restructuring. I would like to very, very briefly address some false beliefs and errors in thinking that Dr. Aaron Beck and other CBT therapists have identified. And so these are the so-called cognitive distortions that are very, very common, and I would assume, so they are not only common among gamblers, they are common among all people, and if you read them, I believe that you will occasionally find yourself also making some of these cognitive errors. I'm just going to zip through them quickly because you can find these lists on the internet, and we have found it useful to share these lists with our clients. So a common error is all or nothing thinking. So for example, you apply for a job, you get an interview, but then they hire someone else and you feel like a total failure. So black and white thinking. Overgeneralization. From one instance, you perceive a pattern and you generalize to everything else. So for example, my husband forgot our anniversary and I conclude he doesn't love me anymore. Mind reading, also a very, very common error, because kind of you think you know what other people are thinking. So for example, my friend didn't invite me to his daughter's wedding. He thinks I'm not good enough. Okay, there may be 1,000 other reasons, and so I certainly do not know what my friend's motivation was. Another very common error is catastrophizing, when you exaggerate something negative that happened in a very unusual way. So for example, let's assume you fail your licensing exam and then you say your career is over. Okay. Here are a couple more emotional reasoning. You judge a situation by the way you feel. So if a gambler feels that today is his day and that he's going to win big, he will continue to gamble until he has lost all his money. A mental filter is another thing that you dwell on the negative side of a situation despite the fact that there might have been many positive things, such as a woman invites her friends over to dinner and the food is excellent, but the pasta was a tiny bit overcooked, and so now everybody praises her, but she feels that she's a lousy cook. And of course, most importantly, the many, many shoulds and musts. Okay, you have strong convictions of how people should behave. And so, like, if I were competent at my job, I should have been promoted a long time ago. So, as I said, these are just some examples. There are many more such cognitive distortions, and we have found them to be very useful, and we hand them out to our clients. So you can look up these lists on the internet and help the client recognize some of their dysfunctional beliefs and label them. We have found it useful. Now let me say something about the role of core beliefs in CBT. So far we have spoken about dysfunctional beliefs in the form of automatic thoughts, which we defined as distorted appraisals of a situation that the person accepts as true. However, there are, in addition to automatic thoughts, also much more pervasive beliefs, and we could view them as rules that a person follows, and these rules are applicable across many situations. For example, if I'm thin, then others will love me. And you can exchange the word thin for anything else. Like if I'm pretty or smart or rich, then others will love me. And so these types of rules stem from an underlying dysfunctional core belief. These core beliefs are global beliefs that are often formed in childhood, and they become deep-seated and unconscious or semi-conscious, in a sense that they are quite often completely out of the person's awareness. These core beliefs are rigid, pervasive, and they influence how individuals perceive their experiences, and they drive their behavior. A typical example would be, I'm an unlovable human being, or I'm a total failure. So such core beliefs lead to rules such as, if I had a lot of money, I would be loved. This is actually probably one of the rules that many of our gamblers follow, because their mantra is money equals happiness and respect, and so on and so forth. Now, for successful therapy, it is important to identify and challenge these core beliefs, because they will manifest themselves in many areas of the person's life, in relationships, in work, marriage, not simply in gambling. And if you leave these core beliefs undiscovered and unchallenged, then the client may remain vulnerable to developing other cognitive distortions and problem behaviors. So it is for that reason that in the course of therapy you will identify these core beliefs. Now when you look here at the gambling episode that we had identified and analyzed beforehand, you see we started with the high-risk situations and the thoughts and emotions that were generated in this situation, okay? But the underlying core belief is, I am a failure as a husband and a father. And so that is the deep-seated problem. I am a failure. And that is what needs to be addressed in the same way as you would address other dysfunctional thoughts. It will take a while. You will use evidence for and against. So what does it mean to be a failure? What does it mean to be a successful husband and a successful father? And what does it mean to be a failure as a father, for example? So what evidence do you have that your belief is correct, and what evidence speaks against it? So it's important to identify these core beliefs. I cannot emphasize that enough. And now let's look at some typical cognitive distortions in gamblers. One of the most common cognitive distortions is the illusion of control. And that is that one can enhance one's chances of winning in games of chance, be that slots, craps, roulette, blackjack, and so on and so forth. Now, this is a very common misperception, and the gambling industry capitalizes on people's tendency to fall for the illusion of control. And so they use skill cues to deceive the gambler. Why do you think slot machines used to have levers, or now they have buttons where you can push and you will stop the wheels? Okay, these buttons have no function whatsoever. The slot machines are computer controlled, but people believe that pressing the button at the right moment will indeed make a difference, so they can influence a chance-based game through skill. It's the same thing, for example, why do you think in lotteries you can ask for either a random pick or you can pick your own numbers? People believe if they pick their own numbers, somehow that enhances their chances of winning. It's absolutely not true. Another very common cognitive distortion are so-called superstitious beliefs. some gamblers believe that there is a particular lucky slot machine and they need to play this machine, then they will win. Or there's a lucky dealer, or there's a lucky table. Some gamblers have lucky charms, and some gamblers believe that their feelings can tell them when they have a lucky day. Others engage in rituals. For example, it's very common, that has been shown in research, when people play craps and they need a high number, they actually throw the dice harder, and when they need a low number, they throw the dice more softly. So, of course, the way you throw the dice has nothing to do with the outcome of the dice, but people are superstitious and believe that. So the important thing is for gamblers, little by little, to understand that all gambling games are games of chance, and they are influenced by either completely uncontrollable factors, or some gambling activities such as horse racing or sports betting are influenced by so many chance-based factors that it is virtually impossible to predict the outcome. And therefore nothing that the gambler does or says will have an influence on the outcome. Another important cognitive distortion is the so-called near-miss phenomenon. Slot machines are often programmed to exploit gamblers' cognitive distortions, and so they mimic an almost win. The first two wheels show fruit, and then the third wheel, of course, does not match. And there is evidence in the research literature that many almost wins, or so-called near misses, influence gamblers to continue playing. Indeed, in Australia, it is prohibited for slot machines to be programmed in such a way that they have more near misses than they would have by chance. Another very common distortion is the gambler's fallacy. This happens when events are independent from one another, but the gambler believes that that future events somehow can be predicted based on past events. So, for example, imagine that you play roulette and you see that red has appeared 5 times in a row. Okay, what is going to happen next? Gamblers would set black. But the chances of red or black being next is exactly the same. It doesn't matter whether there was 5 times red before, or 6 times, or 1 time. The roulette ball does not have a memory. So it is completely irrelevant whether it was red or black, but gamblers believe that somehow, since it had been 5 times black before, it has to be red now, or vice versa. Okay, so in each event is independent in the roulette game, and you cannot believe that the chances of one or the other outcome is now influenced by past events. It's exactly the same thing with slot machines and basically all the other gambling games. So gambling is truly random or chance-based, and every trial is independent. And the house edge in roulette, for example, is about 5%, which means that over time you will lose all your money. Another common distortion is to underestimate the effects of chance and to overestimate one's own skill. That is quite common with blackjack players. The house edge with blackjack with a perfect game is 0.5%, and with an average game it is 5%. So there is 0.5% is the advantage for the dealer, and so even if you played a perfect game, in the long run you will lose your money. And of course, since very few individuals are able to play a perfect game, they lose their money much more quickly. The fact of the matter is, it is a game of chance and it cannot be controlled. One of the worst phenomena is chasing losses, and that happens when a gambler has lost money and now begins to chase the loss and gambles more and more and doubles up because he now wants to recuperate their losses, okay? And again, the house always wins in the long run. Losses that have been incurred cannot be recuperated. Yes, in any one instance it is possible to win more than one loses, but in the long run, going back and gambling and going back and gambling, in the long run the gambler will lose money. So this is just simply a fact, and it is important for the gambler to understand that the longer one gambles, the more one loses, and there is no way in which one can make up past losses, no matter how much one wants to try. Now let's talk about behavior change. The cycle of problem gambling seems endless, and so how do we interrupt this vicious cycle? There are many ways in which problem gambling can be changed. We can think of gambling like a behavior chain. A chain consists of links that are comprised of individual decisions and steps, from the initial high-risk situation to the final outcome. And so a behavior chain is best stopped by interrupting it at the earliest link. And so help the client identify high-risk situations and avoid them. So for example, if a high-risk situation is having a paycheck in the pocket, get temporarily help with money management and don't have that paycheck in the pocket, okay? If there are reactions to events that cause particular mood states, depression or boredom, anger, learn to identify the cognitive distortions that create these moods so that you can change them. In general, help the client identify irrational beliefs and challenge them using the Socratic method and replace them with rational thoughts. Use problem-solving therapy. I used the acronym SOLVED a little while ago, and you can certainly get other problem-solving manuals in the internet. And finally, help the client find activities that are incompatible with gambling. We had a client who retired. He was widowed. He had an adult daughter, but otherwise he was alone, and when he retired he felt very bored, and so he started gambling. And at some point his daughter then realized what was going on, and so she asked him to come to treatment, to our program, and one of our therapists worked with him, and then after doing a functional analysis we recommended that he during the day interact more with his young grandson, and then in the evenings, which was a particular dangerous thing for him, try to find an alternative activity, and that would have been part-time work. And so indeed this client, after a few treatment sessions, found some alternative job in the evening, and this really resolved his problem because he felt useful again. He liked to interact with some colleagues, and the evenings that he otherwise would sometimes spend at the Racino now were filled with a more constructive activity, and his problem was resolved. We have also found that some of our clients have developed alternative behaviors that they have found enjoyable. Excuse me. And so they can replace some of the enjoyment that the clients found, that clients derive from gambling. So for example, one of our clients started going back to a neighborhood bar where dancing was on the program, because she very much enjoyed dancing, and so she used that instead of going gambling. Another client joined a bowling group and went bowling. And so different clients have come up with different ways of filling their time and engaging in enjoyable behaviors. You know, gambling is a very exciting activity for most individuals, and so we cannot expect that somebody would just basically cut out gambling and not replace it with anything else that they find enjoyable. So we need to be a little bit creative and help people find a replacement. It may not, the activity may not be a total replacement for the rush that individuals may feel when gambling, but nevertheless there are possibilities that are satisfying and that are not harmful to the client in the long run. And finally, let me say one word about relapse prevention. Toward the end of therapy, it is important to introduce the concept of relapse prevention because especially after a prolonged abstinence, we have found that a number of clients become vulnerable again through automatic thoughts such as, I think I can now control my gambling, and so I'm going to give it a try. And typically such thoughts lead to a slip. So let's teach our clients to recognize early warning signals, sudden thoughts and urges to gamble, or thoughts such as, it's okay to have fun once in a while. So it's important to remember that gambling is a losing proposition. The house always wins. Explain to the client the difference between a slip and a relapse. A slip means going back to gambling on a single occasion or perhaps a couple of occasions, whereas a relapse means falling back into old habits. And so while it is common in any addictive behavior to have a slip here and there, one can prevent a full relapse by recognizing the danger. If a slip occurs, the client should not recriminate themselves, but remember all they have invested in their abstinence. And so have the client identify what caused the slip, what were the thoughts associated with the decision to go and gamble. And then, well, when you fall off the wagon, you dust yourself off and you get back on the wagon and recommit yourself to abstinence. And if maladaptive thoughts and urges persist, well, then the client should seek support that can be had at GA or with a friend or with a few sessions with the counselor. I always believe that a slip is an opportunity to learn. It is not the end of the world. And when you send this message to a client and the client feels comfortable after a slip to really get back on the wagon or to ask for help and to come back for a few sessions in therapy if this is needed, then I consider that a significant success. And now we have come to the end. When you have come to the end of treatment, it is important to also consider continuing care. First of all, at the end of treatment, we have found it best to fade out sessions gradually rather than suddenly discontinuing treatment. And so we like to spread the final sessions out a few weeks apart, so like 2, 3, or 4 weeks apart, because this gives the client a chance to gain self-confidence, to be on their own. And then we also check in with our clients maybe 2 or 3 months after termination, just to see how the client is doing, and if necessary, we offer 1 or more booster sessions. We also believe that gambling, like other addictive behaviors, creates a long-term vulnerability. And so we therefore urge all our clients to continue in aftercare, GA, other groups, or whatever is necessary. And we also refer clients for additional treatment if there are significant unresolved problems, for example, marital issues, or Some clients get help from a friend or from a family member, and some of them get a tune-up from their therapist, or they come for periodic check-ins, and all these things can be very useful to help the client remain abstinent in the long run. And so now we have come to the end of this webinar, and therefore let me just summarize the main points I have tried to convey to you. So CBT has a strong empirical foundation in research. It is a therapy with proven effectiveness for a range of human problems, including gambling. CBT is a collaborative approach between therapist and client. The therapist assumes the role of a coach or a counselor, and the treatment goals are set collaboratively. The CBT helps clients to get a better understanding of the relationship between the way they think, feel, and behave, and it encourages them to empirically test the accuracy of their perception and beliefs before deciding to act on them. CBT provides clients with tools to challenge irrational or false beliefs, and it provides them with specific coping and problem-solving skills to change maladaptive behaviors. And let me add a final caveat. The purpose of this webinar was to provide you with an overview of CBT and its application to gambling disorders. It was not intended to make competent CBT therapists out of providers who are unfamiliar with CBT. For those providers to become competent and effective CBT therapists, we recommend additional training in CBT and relevant readings, and most importantly, competent supervision of clinical cases. And now I thank you very much for your attention. We are very pleased that you have taken our webinars in CBT and MI with us. If you are interested in additional information about this training or about a treatment that we have developed that incorporates MI and CBT, and that is termed Cognitive Motivational Behavior Therapy, then please contact either me or my colleague James Broussard. You have our email addresses here on the last slide. And so now again, thank you very much for your attention, and all the best.